Hello, guys. Thank you guys so much for coming to the show this week. My name is Kelly Sherman. I'm a junior public health science major at the School of Public Health at the University of Maryland. And I'm so happy to be here and have the opportunity to connect with fellow students and friends to talk about the coronavirus right now. And I was just wondering if Dean Lushniak and Dr. Moser-Jones, if you guys could introduce yourselves and give us a little bit of background about why you're here.
Great. Marion, why don't you start since you're our new addition to this broadcast?
Okay, well, welcome everybody. I'm Professor Marion Moser-Jones. I teach history of public health here in public health science and delivery of human services to families and maternal and child health. And I'm in family science. And my expertise is in the history of public health in the US. And specifically, I've studied the 1918-19 influenza pandemic and how nurses and volunteers addressed it and their role in it, and looking at some racial disparities and gender, how gender fit in as well.
Great, and I'm Boris Lushniak. I'm the Dean of the School of Public Health, and this is my third time on with Kelly Sherman, one of our illustrious students. And I come from sort of a public health responder angle, in that I spent 27 years in the United States Public Health Service Commission Corps, multiple public health crises in that career path, and certainly fascinated and interested and honestly scared by the COVID-19 scenario. But I think one way that we deal with sort of the fear factor is to have forum like this, to have the ability for us to discuss and talk and what's real news, what's fake news, and with the optimism that comes in public health is that we'll figure out a way to get through this. And it is going to take us as a community within the School of Public Health, within College Park, within the University of Maryland, within our state, within our region, within our nation, and within the world. So we will do well ultimately. But there's going to be a lot of scenarios that we need to work through first. So back to you, Kelly.
Definitely. I completely agree. And optimism is very important in this time and every time, to be honest. But this week on our episode, we're going to have it a little bit differently, structured wise. So we're going to have more of a structured talk in the beginning, just about how Black Americans are disproportionately dying from the coronavirus, and also just the current state and ethics of masks and PPE situation for healthcare providers, and different parallels between the 1918 influenza pandemic and also right now. And then towards the last 10 minutes, we'll be taking questions live from the audience. And also, everyone who's watching this right now, thank you so much. And I hope you've found everything okay on Facebook Live. This is just a better way so we could add more people to the call and just have more experts in and weigh in on this situation, which is really amazing. So if you guys could talk about what your biggest focus point around the coronavirus is currently. I know, Marianne, you were talking about the 1918 pandemic, and just from a historian background, what big parallels do you kind of see from then and today?
Okay, well, thank you, Kelly. Thanks all for being here. Yeah, so I've been interviewed by a lot of journalists about this suddenly out of the blue. I had this strange fascination with the 1918-19 flu, and suddenly it's relevant, unfortunately. So the big parallels, I think, are the suddenness. It was a novel flu strain to which people had little to no immunity. You see the pathogenesis that's similar, where you had some people who were getting very sick and having their immune system was attacking the virus, but also attacking them. So what they call an immunopathogenic reaction. And differences are in the 1918-19 flu, those people who had that reaction and the people who were dying of it were disproportionately in the 20 to 40 range. So here we're seeing a lot of elders, middle-aged to elders, but we're seeing some young folks too. Another big similarity is the way we responded. And it was really on, then it was on a city by city basis, and in terms of social distancing measures, which they didn't call that then, they often called it a quarantine. Basically shutting down the schools, shutting down theaters, shutting down pool halls and bowling alleys, making people basically stay home and out of the streets, and in order to limit the spread. And lastly was the wearing of masks, and homemade masks became very important. People knew that it was spread by droplets, that people would cough and sneeze. Of course, here, COVID, apparently you don't have the sneezing, but you have the coughing. So people wore gauze masks, and in some cities, you had requirements. So interestingly, San Francisco passed a mask ordinance in 1918. And I just saw that LA is requiring masks, homemade masks today. So requiring the general public wear masks was a novel thing, and now we're seeing it again.
That is so interesting just to see those parallels, even just like within 100 years. And you'd think that within 100 years we would change so much, but it's really cool that we can rely on like the same techniques and like hopefully get through this as well. Going off of masks, I think there has been like a lot of back and forth with masks, and honestly, like as a student, like I've been confused a bunch about like when we're supposed to wear masks or whatever. But according to like recent CDC recommendations, they recommend wearing like a cloth face covering in public settings and like where other social distancing measures are difficult to maintain, like going to the grocery store, for example, or like the pharmacy or CVS or whatever. So I was just wondering if like we should be wearing a mask while we're going like about like our general like routines. Like I know I personally like take a walk, or like I'll walk my dog outside, and like I was wondering, should I be wearing a mask then? Or like if I'm close to like touching, say like a thing to cross the street, like should I be wearing a mask like in those situations?
Dean Lushniak, do you want to take that?
Sure. So it's sort of interesting, this whole evolution of the CDC recommendations on the mask. So let's go back in time a little bit and kind of look at the progress of this. Because sometimes people determine that, oh my God, the answer is you people in public health have no idea what you're doing, and you're just changing, what you think is the right approach. And I want to kind of dispel that aspect of it. We, first of all, keep learning brand new things about COVID-19, and specifically about the SARS coronavirus 2, which is the actual organism that's causing COVID-19, which is the disease. And every time that we run into brand new information, public health needs to react to it. Right? And so part of this is there needs to be consistent messaging, which there has been a lack of over this time. But consistent messaging sometimes is impossible when we get brand new information. So we start out with this idea of, first of all, that we as a society tend not to wear masks in public. Certainly, we've seen this in other countries where people wear masks routinely. Sometimes we see it on our own campus. And in other cultures, this is more, I would say, almost acceptable, if you will, that people in times of cold season and flu season do protect themselves. To a large extent, that hasn't permeated our society. And I'm not going to comment on whether that works or not, but it is it's almost a cultural phenomenon of mask wearing or not. So we started out basically from a public health aspect saying, all general public do not wear masks, right? Just don't do it. Unless what? Unless you're a healthcare worker, obviously in that occupational setting, you're going to be wearing masks. And our recommendations are that you wear these specialized masks, which are very well designed and do block out the right size of microbes, and they're called N95 masks. And those are for healthcare workers. And then, oh, by the way, the surgical masks aren't as good as the N95s, but in certain settings, healthcare workers, you can be wearing those masks. And then for the general public, we began sort of talking about this idea as, well, it doesn't really work well in preventing me from getting the disease, right? that is the surgical mask, or even now the homemade mask. But initially it was, if you're sick, you don't want to spread it to others. And maybe this will block some aspect of what's coming out of your mouth, out of your nose, and protecting others. So it wasn't so much protecting me myself, it really was protecting others because I'm sick. Now, there was also a stigma now associated with that, which is all of a sudden, is everybody who's wearing a mask at the Safeway sick, right? So we went through that phase for a little bit. Then we ran into further problems in the healthcare world. In the healthcare world, there was massive shortages of the N95s and the surgical masks, and then we started reeling with that. So now we started breaking real basic rules. I'm sure Mary will agree with this. These were basic rules, which was all of a sudden we're saying, well, you know, we always say that these masks are one-time use only, but because we have a shortage, now let's sort of break into this, and we're going to say, well, you know, maybe you can wear it longer. Is that data driven? It is data driven because the mask still works. Is it as good as a fresh mask? The reality is it isn't. Right? And then we started talking about the idea of cleaning the masks, right? This whole idea of disinfecting started playing a role, and there's various modalities and ideas out there about this. And then it was CDC even. And who would have thought in my lifetime, in our lifetimes, we would have seen CDC come out with a guidance saying, hey, worst case scenario, put on a bandana, even for a healthcare worker. That was mind-blowing. I spent 16 years of my life at CDC. I would never imagine that we would get to that stage. But the whole idea was, well, you do what you got to do when you have to do it. And as long as, and this is a big question, as long as there's transparency that this bandana is not as good as the N95 and you are putting yourself at risk, is it better than nothing? Well, probably. Now, for the general public, it goes back to your general question, Kelly, is we've gone even further now. And now it's the whole idea that in general public's world, all of a sudden we went from don't wear masks to now in many jurisdictions, hey, everybody put on a mask. Don't touch the N95s because we have a shortage and those should be used for healthcare workers. Don't even touch surgical masks, but make your own masks. And here's how to make it, right? Washington Post this week had this. You can find it online. The Surgeon General's talking about it. Right? We get into all this, and now we're all supposed to be wearing masks. And back to your question, when are we supposed to be wearing them? Well, we wear them when we're trying to protect others from us, because all of a sudden there's brand new information. And what's this information showing? It shows that, you know, first they said 20%. Now they're saying upwards of 50% of people who are carrying the virus may be totally asymptomatic, right? So I feel pretty healthy right now. Haven't had a cough, haven't had a cold, knock on wood. It doesn't mean that I didn't get this virus from somebody, and it may not mean that I'm not spreading it to somebody. So the whole mask use really is, think of it as a protector, protecting others, right, from you potentially. And where you wear it where you're going to be around other people, right? And maybe where the 6-foot rule may or may not be applicable, you know, may or may not be difficult to sort of implement. Right? And this is the whole idea. You go into a grocery store now, it's supposed to be separated, but put on a mask because that's an extra feature. You stand in line at the pharmacy, you do that. If you're going out for a walk and you're running into other people along the way and the 6-foot rule may be an issue, put it on. So many jurisdictions are now going into that realm. So there's no real super clear answer nor scientifically valid answer, right? Is it helping? We'll determine. Mary, what do you think?
Yeah, I agree. And I think one thing that really struck me as wise is Deborah Birx, who's of course co-leading this, you know, the White House coronavirus response team position. She said, you know, we don't want people to get an artificial sense of protection because they're behind a mask. So in other words, keep social distancing, keep washing your hands. And don't go out if you don't have to. So the one thing about masks I would say is don't, you know, some people might say, well, now that they say wear masks, just put on the mask and go out and, you know, enjoy yourself. Well, I would say don't do that unless you have to. And I'm also looking at that in terms of if I go to a park, well, if the park is someplace where I can always stay 6 feet away from people, there are very, very few people there at one time, and I'm taking my daily walk with my big dog who scares people, well, maybe I don't need a mask. But, you know, otherwise, what is the harm of wearing the cloth mask? And the last thing I would say is that our Surgeon General, our current Surgeon General, Jerome Adams, has this neat little video where he makes, I don't know if you've seen this, where he makes a mask out of t-shirt material and 2 rubber bands. And my concern initially was that all of these mask making patterns and calls were going around the internet, and it was for people who had sewing machines. And that's wonderful. Some people get into that and they craft and they sew, but a lot of us don't own a sewing machine in this 21st century era, or we're busy with childcare or elder care or both or work. And we don't have that. And it's stressful to think about that. Oh, do I have to learn to sew? And so I think Dr. Adams' video is brilliant because most of us have a used t-shirt or a t-shirt somebody else doesn't want us to wear. I don't know if you saw Trevor Noah, how he got tricked into basically ripping up these t-shirts that his coworker didn't want him to wear anymore in order to make a mask. So you have one t-shirt that maybe you're not your best t-shirt, and you have 2 rubber bands and you can make a mask.
That's such an innovative and like fun way to make a mask too, especially during this time, like when you just need an outlet. Professor Thomas, welcome to our show. My name's Kelly, and I was just wondering if you could give like a quick like introduction to everyone.
Did you ask a question?
Oh yeah, no, I was just wondering if you could introduce yourself.
Oh, okay. I thought you said Kelly. Okay, I'm
No,
Dr.
so
Stephen.
sorry.
That's okay. I'm Dr. Stephen Thomas. I'm a professor in our Department of Health Policy and Management, and I direct the Maryland Center for Health Equity. Sorry for being a little bit late. And in fact, a Canadian broadcast camera crew was just in my front yard. They were all in mass and 6 feet away with a big boom mic. So the Canadians have arrived, and they're leaving me, and they're going to our barber shops where Fred's going to open up one of the shops. The message there had to do with who's giving this message to the minority communities. It's not just the message, it's also the messenger. And in many of those communities, the messengers don't have PhDs or MDs. They have credibility, and they have trust. We also need to make sure that we provide them with the information they need. Because a lot of the scientific evidence-based information, guess what, lives behind paywalls. From the New York Times, Wall Street Journal, all the major publications, even our scientific medical journals, even when they're speaking to the public, they're behind paywalls. But trash and misinformation and myths flow like water. And we need countermeasures out there to address that. And so we want to mobilize our barbershop and beauty salon network to ensure that they have accurate information. And we're at the beginning of this. I'm hoping the deans said the metaphor is definitely not a sprint. This is a marathon, and it could be seasonal, which means it's going to come back. And so now is our time to batten down the hatches and really strengthen that public health infrastructure. For many of the parents of our students, they finally realize what their students are majoring in. So I thought you wanted to be a doctor, but you want to be an epidemiologist? What's an epidemiologist? So America's finally learning what public health is. This is our moment, and it will either cover us in mud or glory. I think it's very important that we lift up that public health infrastructure. It is not something the private sector can do. It is the common good. It is the foundation of what keeps people healthy, and it's only evident when it's broken. Now it's broken, and when we fix it, we must fix it together.
I completely agree. Yeah, that's so true. Also, just like talking about public health and like what public health is. So many of my friends and family members have no idea. Like they know I'm a public health major, but they have no idea what that means. They'll just be like, "All right, Kelly, that's great." And now, like since it's always in the news, like people are so fascinated and just like seeing like all the hard work that epidemiologists have been doing like for the past like 10, 15, 16 years. Like that's amazing. Like that people are having like this like ability to track different infectious diseases and like see mortality rates and morbidity rates and like use that like scientific data and try to analyze it in a productive way going forward. But there are lots of like flaws like in our community where like just our healthcare system is not good enough, and just different things like people are not getting adequate care that they deserve and that they need to be treated properly. And like that goes to so many different communities, like even communities on campus, like different people without health insurance or people living paycheck to paycheck and other like marginalized groups and they who just can't afford to miss work and they have no like steady healthcare provider and there's just no way for certain people to avoid like crowded conditions. So like how can we as a community as like public health leaders like help the healthcare and like safety for these like most vulnerable populations?
You know, I think we're actually doing that in public health in general and at the University of Maryland in particular. A recognition that we are a land grant institution, a recognition that our reach, our mission, our responsibility includes the entire state of Maryland. And I think that reimagining that land grant mission has put public health at the forefront. Many of they've heard epidemiologists and they're seeing all the clinical people, but all the folks doing that testing in the labs, those are public health labs. You know, the public health educators. We have a public health historian right here on the screen with us, and she would tell you that back in 1918, when we were also putting on masks, right? When we were also sewing. Imagine this. Here we are in 2020, and we're using the same mitigation strategies that we used in 1918. What does that tell you? And what does it tell you if you read that history of 1918, how Black people were treated back then, how people of color were treated back then. Even the minority health professionals were marginalized. This is our opportunity to bring our country together in ways that have never been possible, I think, before. These issues we're talking about are structural. They were there before COVID-19. They've now been put on the front pages of the news now. We must seize this moment because unlike HIV/AIDS, you cannot shake a person's hand and transmit AIDS. But when it comes to COVID-19, it is passed casually. And therefore, we cannot afford to have any community, poor, minority, or otherwise, harbor this virus. And so my argument and point is that we cannot be colorblind in our approach, and therefore the data on racial and ethnic breakdown is very important. And I'm wondering, I'm going to throw this to the Dean, Kelly, if you don't mind.
Yeah,
because we're all talking about these models. We're all talking about these models, Dean Lushniak. These are mathematical models, right? And they're populated with data from China and Spain and Italy, and even data from the United States. And there's a whole lot of assumptions. I have my historian here, Mary, and they're making assumptions based on history and what has happened in the past. And here's my question, Dean. Do the mathematical models include assumptions about racial and ethnic health disparities? And that they just haven't reported it for whatever reason, or it's just not on their radar screen? I can live with they're not reporting it for technical reasons, but if it's not on their radar screen, it says to me, who's in the room? Who's in the room where it's happening? And how can we make sure that they start incorporating these racial and ethnic disparities into the mathematical
Yeah, as far
models?
as I know, I don't think they do take into anything to deal with, the differences we see. I mean, the social determinants of health in general are not incorporated into the mathematical models. You got to realize the mathematical models are really, are sort of the crude measures of, you throw in a bunch of things, you look at history, you look at COVID-19 to date, but the assumptions are really sort of wide ranging. Everything from that basic epidemiological term of R naught, right, the number of the R little zero for our epi students out there, which is in essence the number of people that an infected person will infect. So that's in the range in many of the models. But also many of the models assume something that's now only being taken into account, which is they assume that we would do nothing as a society. The worst case scenario models were business as usual. There's no social or physical distancing. There is no closure of anything. And this is how bad it'll be. But you're absolutely right, Stephen. I think to a large extent is what's been neglected in the mathematical modeling is how do we look at our various levels of care in communities? How do we look at the various levels of risk factors in communities? You bring up the issue of, the differences that we're seeing that are shocking differences within the realm of mortality within the African American community. And yet why aren't we as shocked as we should have been when we talked about the chronic diseases in that same community? Because the two may be very related. So my sense, once again, is as an optimist in public health, is that we really learn from this. And now, when all this is over, right now the crisis is at hand, we have to deal with the crisis, and we have to deal with it at all levels in all our communities. But ultimately, is we have to go back to the basics, which is why are we living in a society where we have somehow accepted that chronic diseases occur in certain populations? And so who really cares? Well, this is a sign that we need to read.
And Marian, I'm thinking as a historian, sorry, Kelly, but I would say I'm looking at Marian and all the work you've done and recognizing that, what are those lessons? Because we're using a lot of this computer technology and artificial intelligence, and it's got a lot of buzz, but we can end up with algorithms of oppression if we're not careful. What do we know from history, and how can we get that historical context incorporated into these assumptions?
Well, we do know from history, and not just 1918-19 influenza. In 1918-19, first of all, it wasn't a reportable disease, period, in a lot of places, influenza. And then in terms of reporting racial differences, that was something they didn't do enough. And then there was also health departments around the country did not have personnel of color. There was rampant discrimination against African Americans and other people of color in terms of just hiring for health departments. So they weren't reaching out to the communities. But it's interesting because especially the Black communities in, say, New York and, say, Washington, D.C. And elsewhere had their own community-based response that was often led by nurses and doctors who were at the time very community-minded and public health-minded as well, because they had to be. They knew that there were disparities then in terms of mortality rates. Then tuberculosis was the leading killer, and tuberculosis was a risk factor for dying of influenza. In fact, after the pandemic of influenza, tuberculosis deaths went way down because the most vulnerable people with tuberculosis had died in the pandemic. And so Black American nurses knew that, and they really sought to get involved and to volunteer. And the American Red Cross turned them down, eventually let them in, and quote, a few were allowed to go nurse in the pandemic. Black doctors also had the doors barred of hospitals, even during this horrible pandemic. I mean, the case fatality rate was around 2% or higher in the US. It may have been as much as 10% elsewhere, meaning we had 25 million people who got it and about 550,000 excess deaths, so a lot. And yet this discrimination persisted. So I think there's a myth that somehow in tough times we all pull together. Sometimes that could be true, but with the last big pandemic, that was not true until it went on for a while. And then there were some in the majority community who said, oh, we really need these Black nurses and doctors. And some of them treated and welcomed the Black nurses and doctors, a few to join, not everyone. Others were not respectful, and I think treated them as inferiors. So I think we have to look at that. If there's discrimination against healthcare workers, and I bet that hasn't gone away. We do have a lot of, in the nursing community, a lot of women of color, a lot of Black women who've been leaders and pioneers in nursing, and now nurses are not always being accorded the respect they deserve. They're not always getting PPE and masks. They're being asked to reuse masks. Nurses are dying on the front lines. Nurses United, which is a leading nurse union, is basically saying this is what we need. We need to be told if there are cases, we need PPE, and we need, to be able to quarantine ourselves if we're exposed. So that's a real issue. That's a then and now issue, and I think that can tie it together. The way nurses then stepped up, and Black nurses especially, and the way nurses are stepping up now and not always being given the protection and safety they deserve.
Well, that history, I'd love to think that all of our students are getting that history, because that helps us contextualize what we're facing today. Um, so, you wonder why there's a National Medical Association or a National Black Nurses Association. It's because that structural institutional racism kept them out of the groups. And so here's the irony. Here's the poetic justice, Kelly and Dr. Lushniak. Here we have the president of the American Medical Association, an organization that at one time discriminated against African Americans. The president is an African American woman. That's huge. And the megaphone she has is vitally important to get out.
I think it's important. The megaphone is important, and now the megaphone goes back to Kelly. Kelly, what do you got for us?
Yeah, no, it definitely is really important. And the outbreaks just in general are such a wake up call, about just health gaps and just about income and privilege and race just in our society. And this isn't the first time that this has been happening. But how can we promote future policy changes about some of these inequities faced in our society to mitigate these inequities for the future? And how can we go forward and figure out how to decrease the gaps within these different inequities?
Stephen, why don't you start on that? Yeah.
Well, we had already started. Part of it is many of these initiatives that we have in our School of Public Health, in our Center for Health Equity, and even the field of health disparity research, which is now maturing. We've been working at this, but we've been working without all the tools, without all the resources. Basically, we've been working and begging for resources. And so hopefully this is a wake-up call so that the issues that we've been on the forefront of get more visibility. And they'll realize that a lot of what we've done, we know more now than we've ever known about how to actually prevent disease and promote health. But a lot of that information lives in our medical journals, again, behind paywalls, in language not accessible to the general public. I think that coming out of this, we must recommit our effort to translate that science of medicine and public health into culturally tailored, community-based interventions. We must get off of our campus. We must go out into the neighborhoods and deliver a message that can save lives. And hopefully, there will be more resources there to help us do that. The frontline public health workforce cannot do it alone. We are an academic partner that can add value. And our students, just like the medical students that were a fast track to graduate, get on the front lines in the hospitals, we need to think that same way about our own public health students. How do we mobilize them now? They don't have to wait until they graduate to get mud on their boots to see how public health works. This is a historic moment. And I think we should make and create creative opportunities for our students to be part of this.
Absolutely. And I just speaking with history, I mean, I'm thinking of, as far back as the Spanish-American War, when, I knew nursing students and medical students interrupted their studies to go, be on hospital ships with the Red Cross or military. And same with World War I, and World War II. It was, and they realized it was an opportunity to do service for their country, and also an opportunity to learn quite a bit. And I think it's similar now in terms of, this is an unprecedented opportunity for you as public health students to learn about what public health means, all the things we've been telling you, and sharing from the past or from textbooks are now coming to life. So, to the extent that you feel safe, and also there's so much that's being done through technology these days, that you can get involved in many different ways in, anything from the Medical Reserve Corps that we're, Dean Lushniak has asked us all to sign up for as we're able to volunteering, if they're in specific opportunities with the health department, which may happen. As Dr. Thomas says, this is a marathon. We're only in the beginning of the beginning right here. And so there are going to be opportunities that come along in order to meet the longer term emergency, the longer, as this develops and as this continues.
Kelly, it's so important that we have those lessons from the past and recognize that these are structural issues. We don't forget, at the beginning of this pandemic, coming out of China, many of my Asian students felt the pressure of feeling like they were kind of being looked at, and they could feel the difference. Okay, now we're all in this together. I love that. But we must also embrace the fact that we must recognize our diversity. And so, Dean, I think that we talk about the disease detectives at CDC, the Epidemic Intelligence Service, which I think is just a marvelous program. I think we need to put our heads together right here on this Zoom and think about a health equity intelligence service, where we become the place in the country where scholars come to learn these mitigation strategies, that learn these cultural tailoring strategies, that learn how to translate science into public health interventions. That's an intelligence as well, a health equity intelligence service.
And certainly, I think, when we look at the at-risk populations out there, we have the data now more so today than we even had yesterday and the day before. Dr. Thomas, a few days ago, sent me an email and said, is CDC gathering this information? And the reality at that point is the answer was, I have not seen it. And if they have it, they're certainly not sharing it with the public. Well, I think it turns out that we're now being told that now everyone's going to start gathering this information. And part of this comes from the community activism, which is all of a sudden you have observational science, which is doctors and nurses and healthcare providers and everybody working at the hospitals, which, by the way, includes the cleaning staff, right? And everyone, they're all heroes as well. Notice that there's a disproportion going on right before their very eyes, right? When the person on a ventilator happens to be a person of color, and the next person happens to be a person of color, and the third person, then there's a pattern. And I think that sort of activism occurs, and all of a sudden the world starts paying attention. From our school's perspective, Dr. Thomas, you're in the driver's seat to a large extent. You're the director of the Maryland Center for Health Equity. And the question is, what can we possibly do at this stage? I think, one thing is what you've done very well already is, you're talking with the press, you're talking with the media. Part of it is to get that word out. Part of it is to look at what can we do within our communities, and certainly the barbershop and salon community centers, for want of a better term, have a role in all of this, right? And so we have a lot of work ahead of us.
I was thinking about the fact that we have to figure out a way of keeping these public health metaphors out there. The images now are pretty much clinical. And a lot of that public health workforce is kind of behind the scenes and not always visible. And Kelly, I'm going to put the burden on you as a young up and coming young professional to help us think very, very creatively, to help us truly get outside the box, bringing the public health theme, the public health metaphors to the forefront.
Gladly. I won't be able to take the entire burden, but I will work with that. I'm not that put together.
and I want your peers to think about the ethics, the public health ethics. In our communities, there's a lot of fear. I mean, a number of African Americans and other minorities don't sign the organ donor card because of their fear that somehow if they really needed life-saving intervention, their organs would be more important than their life. And so when you're reading in the paper today, not as a tabletop exercise, but in real time, how hospital systems are having to make ethical decisions around how do we ration limited resources like ventilators. Do we prioritize physicians over nurses? Do we prioritize health professionals over that janitor cleaning that room? These used to be classroom exercises. Now it's a reality. And I think that that has stunned a lot of people to think that we are having those kind of decisions in the United States of America.
I've seen even like, this is a very like not professional source, but there's a social media app called TikTok that lots of like people are on. And I saw this one video that a nurse posted where she was crying on her way to work, like just saying like she was going to have to make those decisions, like who to put on a ventilator and who not. And like she knows that she signed up for this, but also it's just like heartbreaking to be thinking that like we have to be like making these like decisions as healthcare professionals, and like we have to make sure that like biases and different things do not get in the way of these decisions as we're going forward. And it's a very like unprecedented time, which is very strange. But as like different policies and like changes are being made like to help the next like I think group of like public health professionals to like research like ethics and different things regarding public health for potentially the next pandemic, what do you think that the steps should be in like regards to like data and like data collection? Because like we've been talking about like communication and communicating this data, like do you think there should be like more steps talking about how to like make this data accessible to different communities, and then also just like it kind of put it in like layman's terms for not healthcare professionals, like what can like CDC or like different organizations do for that?
Let me just very quickly say, you know, the data analytics and data vision has, there are probably even examples from a 1919 flu pandemic of the different visuals that they came up with to communicate what was happening. But my biggest concern is that data without action is a problem. We've been collecting data, for example, on health disparities for decades, and yet the people are still suffering. And that's one of the dilemmas on the community side. They say, hey, you've been surveying us, you've been taking blood samples, you've been poking and prodding, and we still suffer. I think we have to lead with action, but the action must be informed by good data that includes all of the data. We can't do it colorblind, but it is not simply data, it is also to take action, or else we leave these communities potentially stigmatized.
Yeah, and there's also, I think from 1918, you know, they had data, they had, you know, graphs and things like that, and they were charting peak mortality, and they would, you know, have daily reports in most of the newspapers as, you know, of the number of cases and the number of deaths in most cities. And in some cities they did report. In Baltimore, they reported by race infrequently and not in a consistent way, but they did. And it was very surprising because there was an assumption, somehow there was a folk idea that African Americans were immune from influenza. And in fact, in Baltimore, the African American mortality rate, the Black mortality rate was higher, at least as reported in the paper, in some periods of the peak than the white mortality rate was. And the cemetery where African Americans were traditionally buried ran out of graves sites, and it was really, you know, it was really horrible. So that this really, you know, is something that's a continuing issue, but it was put under the surface. The media wasn't reporting it, except, I mean, the Black press was reporting it a little, and the newspapers at the time. So I think we see a repeat in that. I've seen this issue of disparities reported in news outlets that address Black communities. So an ESPN has this blog called The Undefeated. They've been covering this racial disparities issue for a while. They had a great interview with Georges Benjamin, the head of our American Public Health Association, on March 15th that was published, and he predicted everything that's happened, which is the disparities. So I think we need to also push for the mainstream over dominant media to be getting this out. It's not more graphs, more charts, but more of stories with people in them, and to get the right message, because the other thing we can learn from history is there's a lot of misinformation, as Dr. Thomas has talked about, that floats around. And one of these, I would call it a racist trope, is this idea of that there's some kind of genetic vulnerability. So if you see, there are two sides. There's the trope of African Americans are immune to this, which was yellow fever traditionally, which wasn't true, and then influenza, also not true. And then there is this historical trope of genetic differences between races, which of course isn't proven by science, and that one group is somehow genetically more vulnerable. So with tuberculosis, there was a belief and promoted among white scientists, especially, that African Americans, Black Americans were more vulnerable to tuberculosis genetically. And of course, the truth was, just like today, it was conditions. People were being forced to live in more crowded locations where you didn't have regular visits from, the street cleaners, and to work in jobs where you were more vulnerable. So I think we have to bring this to the forefront. And since you have social media now, like, as public health students who are informed, you can be influencers on social media, on TikTok, on Twitter, on Instagram, and be taking the credible sources and retweeting them, or making videos about them and saying, this is the situation. Communities of color are more vulnerable because people are working in jobs that expose them to more, COVID. They have to work outside the home. There are many Black healthcare workers and healthcare workers of color, and because potentially of underlying conditions that are rooted in these health disparities and in lack of access to healthy environments. And so I think that's a really critical thing that everyone who's in public health could do. Every undergrad public health student who understands epidemiology and understands public health can get out there and be countering this misinformation.
The other thing that I want to mention, Kelly, to your point is, let's also put it into reflection of how soon we're into this, right? How early we're into this. So there's a good point to this. The good point of this is, yesterday, I think if I look at my timeline, was 3 months ago yesterday was when the virus was actually first identified as a brand new virus. 3 months, right? That's 12 weeks. The scary part is, look at all that's gone on in these 12 weeks. The good part is, look at all the progress in these 12 weeks. The unfortunate thing is, look at all that we've neglected in these 12 weeks. It's good, though, that we're having this conversation a mere 12 weeks in. People have died, and we certainly share our deepest feelings towards the people who are affected. But we can start making change right now. And it starts out very basically. First, you start in epidemiology of just trying to count accurately. We still have questions how accurately we're counting. And it's simple. It's numerator, denominator. It's number of people who have died over number of people of disease. We began looking at patterns. Why is it that Italy is now at 12% of crude fatality rate, and Germany is only at 1.5%? Now we have to delve in even deeper, which is, as we identify high-risk groups, and the initial high-risk groups were simple, right? It was looking at age. Well, that's a simple epidemiological parameter to look at. And then you look at chronic diseases. Now we're looking at the idea of the social determinants of race as a factor. We need to tackle this just as aggressively as we did with the age distribution and the chronic disease distribution, right? We have lost precious time, but now is the time to really take the time. Back to you, Kelly.
Yeah, definitely. Just being conscious of time, I wanted to give light to some Facebook submitted questions. So one question that was submitted was directed towards Marion. And it says, based on what has happened during past pandemics, what policy changes might we see post-COVID? Like, we've seen lots of people advocate for universal health care, public health preparedness, and strengthening our labor protections, given that everything's going on. But what do you foresee happening?
It's hard to know, partly because it's hard to know how long it's going to last. We're in it. I mean, if I just looked at the 1918-19 flu, I would say that it didn't lead to a huge shift in policy, unfortunately, although it did. I think public health definitely was seen as more valuable. I mean, you see a lot of health departments in the 1920s, public health, which had a lot of growth. And the 1920s wasn't an era for growth of government generally, but there was a lot of philanthropic and local government investment that continued in the 20s and 30s. So you might see that. Another thing I would say, though, in general, I mean, there are other examples of epidemics and pandemics where you see greater organization of public health for the next time. So some people have been comparing this to cholera as well, which became pandemic suddenly in 1831. It came out of nowhere. It was endemic in one river in India, and with colonialism and the British, they brought it back on their steamships, and it spread across Asia, Russia, Europe, US. It was a horrible disease. It was terrifying. People died within, a day, sometimes in the streets. And it hit in New York, especially, it hit disproportionately poor people and immigrants. And then when there was a free Black community and it came back, it hit that community too. So you have those. Cholera, the revisitation of cholera eventually led to strengthened public health departments where you had reinvestment in public health. So I'm going to say, being conservative, as far as, I don't mean ideologically, but I mean in terms of my guesses, I would say, I hope, and I would think that after this, we're going to see a reversal of what we've had, which is the disinvestment in public health at the local, state, and federal level. We've got to, but it's not going to happen by magic. We've all got to push for this. And this isn't a partisan issue. It shouldn't even be a political issue. It's sort of like reinvesting in infrastructure. Everyone should want that, right? Well, our public health infrastructure, just like our roads and bridges, has been crumbling and unattended. And just like after 1849 cholera, New York City and Baltimore, other cities started to step up. So when it came back each successive time, it was less severe after that epidemic, after that global pandemic. And you also had important science. Science became more important. People started to pay attention to sanitation, and then eventually to this, strange physician scientist who mapped out cholera named John Snow. Eventually they accepted his ideas. So, I'm hoping we're going to see a return to people focusing and believing health science, and a return to investment in public health. And now I'll get off my soapbox.
And Kelly, I think there's another opportunity. Think back to polio. I've met adults who remember that period, and they pulled out a little badge. They were like polio heroes, a little badge that they would wear. And so one of the things that we have to consider is how we ensure diversity in the clinical trial participants. This is an opportunity for African Americans and Latinos and other minority groups to be part of the solution, And it's my hope that we redouble our efforts to ensure that those clinical trials are indeed diverse.
Definitely. Dean Lushniak, do you have anything to say about future policy things after post-COVID, or any ideas?
Well, it's interesting. Getting back to what Marianne started, saying in terms of there needs to be a reaction and we need to be part of the activists. I'm asking all our students, everybody on the University of Maryland campus, get your friends and neighbors involved in this. Now that they have found out what public health is, it's not time for us to be reactionary to say, okay, we're now, this is it, crisis over. What we've seen time and time again, certainly in the 21st century, is every time we run into a public health crisis, everyone tends to be interested. And then within a year or two, everything goes back to the way it was. We can't afford this to occur. I was on earlier today with a Washington Post columnist whose article allegedly coming out on Monday is going to be on this very theme, which is, once again, what happened to public health and why are we having this problem? And part of it is, we can't just point towards others. Part of it is we have to be better at what we do. So we have to learn our own lessons. But the reality also is that, we've lost 23% of the public health workforce since 2008. That's 50,000 people at the state and local level that were let go, right? Because all of a sudden, governments decided, it's not worth investing in. Public health is not really doing anything. It's not solving problems. We're now suffering for that decision. We also, and this is encouraging, I think, for you as students out there, have to realize that we also are an aging workforce in the local and state health department. Right? I think the latest information I have here is that 55% of local public health professionals are over the age of 45. And almost a quarter of health department staff are eligible for retirement. So combine those two things, which is right now we understand we have to have growth. We need government level support. We need funding. We need to be able to not be a minuscule factor of the whole healthcare budget. We need to be out there getting a larger percentage of the investment in healthcare. And then your generation, Kelly, needs to be educated, right? And hopefully you're getting that at the University of Maryland. You need to pursue the mission of public health and do it right. We're going to pass the baton to you rather quickly, and let's all learn together.
Definitely. I cannot wait to work together, but also I think we're working together right now. Like even just like having a forum or like a place for people to talk and like express their doubts or concerns, like is a way to communicate with people and like have people more educated and like understand like confusing topics or even just like have a place to vent. But thank you guys so much for like all that you guys are doing, and thank you so much for joining me this week and next week. Please, if you're watching this, like submit questions, and I look forward to talking to you guys more about this and helping our community, our TERP family, and just everyone else as we go through this such tumultuous time. But
great.
Thank you guys.
Thank you so much, Kelly. Thanks.
Thank you. Yeah.
Of course.
Take care. Bye.